Dear colleagues, today I'm presenting a rather particular and rare case. In fact, it's about a patient who had a high-risk result for trisomy 21 on the non-invasive fetal DNA test, after which I performed an amniocentesis. And the initial FISH result indicated a suspected Down syndrome mosaicism. It is well known that Down syndrome is a condition characterized by the presence of a total or partial extra chromosome 21, with a prevalence ranging from 1 in 400 to 1 in 3,000 live births. The causes can be, in 95% of cases, an extra chromosome 21 due to meiotic non-disjunction of the chromosome. In the remaining 5% of cases, the extra chromosome or parts of it are translocated onto another chromosome, as in the case of Robertsonian translocations. Within this 95%, actually about 2 or 3%, a low percentage, is characterized by mosaicism, meaning a triple copy of chromosome 21 is present only in some cell lines. From an ultrasound perspective, there are several signs associated with Down syndrome. Many of them, fall into the category of soft markers, which are the ones you see here highlighted in bold on the slide. These are ultrasound signs that, when considered individually, so when present in isolation, do not have pathological significance. However, their combination, or their association with other anomalies of a morphological or structural nature, obviously raises a strong suspicion for Down syndrome. Among these are an increased nuchal fold, which is very specific for Down syndrome in both the first and second trimester, an absent or hyperplastic nasal bone, a reduced length of the rhizomelic segments, meaning the humerus and femur, a single umbilical artery, an echogenic focus at the cardiac level, known as the so-called golf ball, and others that are also listed here. Other ultrasound signs, on the other hand, fall under structural anomalies that have been more frequently associated with Down syndrome. Among these, at the cardiac level, we recognize the atrioventricular canal, interventricular defects, and tetralogy of Fallot. Among gastrointestinal malformations, esophageal atresia is known to be very common in Down syndrome fetuses. Therefore, we proceeded with an in-depth study of fetal anatomy in order to rule out these signs of any other associated anomalies. Here you can see the study of the skull, specifically the posterior cranial fossa, which appeared to be normal. We then moved on to observing the neck, also in longitudinal section, in order to rule out any actual increase in the thickness of the nuchal fold. After that, in studying the head, we also focused on evaluating the cephalic index, the ratio between the biparietal diameter and the fronto-occipital diameter, so as to rule out a condition of brachycephaly. In this case, the index was above 80, so it was indeed a mesocephalic fetus. Here we can also see that the profile appears regular, the nasal bone is present and is not hyperplastic, as its size is also normal for the gestational age. As for the study of the abdomen, the stomach is present and there are no signs of increased intestinal echogenicity or other abnormalities. There are also 2 umbilical arteries present, and they wrap around the bladder in a normal way. The spine appears normal. We then moved on to the study of the limbs, focusing in particular on the proximal segments, specifically the length of the femur, and later we will also look at the humerus, in order to rule out any shortening of these bones. At the level of the feet, the sandal gap sign was ruled out, that is, an increased gap between the first metatarsal and the others, and in fact, the feet appeared normal. Here we see the proximal segments of the upper limbs, so the length of the humerus, which was normal for the gestational age, as was the femur. We then focused, in order to rule out clinodactyly, which is another characteristic sign of Down syndrome, on the study of the fifth finger of the hand, that is, the fifth metacarpal, which turned out to be normal in both hands. We then moved on to a detailed study of the cardiac anatomy, for the reasons we just discussed. Obviously, heart defects are present in 50% of Down syndrome fetuses. So, we went on to observe the interatrial septum, examining both the primary and secondary septa, and got a good view of the right section. We assessed the normal crossover with the help of color Doppler, so, to evaluate the crossing between the pulmonary artery and the aorta, a good 4-chamber heart view with normal valvular motion, and the right aortic section, which appeared regular. The right subclavian artery, with a regular course, passing in front of the trachea. So we ruled out an aberrant right subclavian artery, which is another of the soft markers frequently associated with trisomy 21. Here we see good continuity between the interventricular septum and the aorta, also ruling out any associated conotruncal pathologies, such as tetralogy of Fallot, which is another heart defect frequently associated with trisomy 21. Therefore, what we have observed is a fetus that does not present any structural anomalies detectable at this gestational age. Nevertheless, the counseling provided to the couple focused on the difficulty of being able to establish a prognosis specific to this case, given first of all the rarity of the condition and the scarcity of cases reported in the literature. But above all, the aim was to raise awareness, even though it was a suspected mosaicism, about the fact that it was not possible to rule out unfavorable neurological outcomes and possible intellectual disability. This is because the outcome obviously depends closely on the percentage of mosaicism detected in the final result of the fetal karyotype from the amniocentesis, and on the cell line affected by this condition of mosaicism, if it is eventually confirmed, something that, of course, cannot be determined during the prenatal period. The final result of the amniocentesis confirmed a mosaicism involving 28% of the cell lines, and therefore the couple will complete the genetic reassessment in light of these final results. Thank you for your attention.